Hello, my name is Julie Balat, and my chosen special population is refugees, and more specifically, healthcare access for refugees. A refugee is defined as a person who has been forced to leave their home country in order to escape war, persecution, or natural disaster. A refugee's vulnerability flows primarily from a failure of that person's home country to meet their ecological needs. This then increases that person's vulnerability as they are forced to move to a new geographic area where their race may decrease their ability to receive health care. This PowerPoint will look at two main themes of barriers to care that refugees face: cultural and structural. First, we will begin with cultural barriers to receiving health care. A study by Project Muse at Johns Hopkins found that mistrust and perceived discrimination deterred refugees from receiving care. One patient best summed this quote by saying, quote, "Doctors don't pay much attention to immigrants. See us fast just to finish and don't listen. They know we don't have documentation, so can't complain. If American, I would surely get much better care." End quote. There is an overall sentiment that Western doctors are only motivated to practice healthcare for the money. Perhaps this is just because the American healthcare system is so bloated and expensive. Another cultural barrier comes from a study by the University of California, San Diego. This barrier is called acculturation differences, and it refers to the differences in culture and environment from the home country to that of the new country. It is very difficult for refugees to jump from one culture right into another due to the journey they have taken, often involving loss of family and a loss of identity from their home country. This vulnerability manifests needs as mental health conditions, such as stress or guilt from leaving their own lives. It is these mental health illnesses like depression that may further deter refugees from seeking medical care. I will now take a minute to highlight mental health care in refugee populations and use it as a case example for the vulnerability framework. The most common mental health diagnoses associated with refugee populations include PTSD, major depression, anxiety, panic attacks, and adjustment disorder. Children and adolescents often have extremely high rates of PTSD, ranging from 50 to 90% of the population. The predisposing characteristics in this situation is that refugees are a specific demographic in the population, and often of a different racial, ethnic, and/or cultural background from the majority of the new country. The enabling characteristics are that they have been forced to move from their home country into a foreign territory and are often uninsured, homeless, and may not speak the language. These prior characteristics manifest the need characteristics of mental health disorders. Building from that sentiment, a study by the Medical Journal of Australia found that additional cultural barriers to preventing access to healthcare include language barriers, low levels of education and literacy, a lack of transportation, and poor understanding of the risks of illness. Refugees may also fear negative social consequences as a result of having infectious diseases, such as the fear of job loss or loss of refugee status, causing some to become secretive about suspected illness. These enabling characteristics prevent refugees from feeling comfortable to seek care and increase their vulnerability in a vicious cycle. This graphic resonates with the Rylak video, which says 14 out of 100 people cannot read or write. With only 50% of refugee children attending primary school, many are certainly part of the 14%. We will now switch to look at the structural and systematic barriers for access to healthcare. One such structural barrier that prevents refugees from receiving care in host countries is that it costs too much. A study published in the Oxford University Press found that 50% of refugees in Canada were not able to receive care because it was unaffordable. Costs associated with healthcare include both time and money for the actual services, transportation, and care for dependent children. Another structural barrier preventing care is gaps in knowledge of what can be provided and received on both parts of healthcare providers and refugees. A study was conducted in England, which surveyed both providers and refugees. Worryingly, the survey found that 36% of healthcare providers did not know that all refugees are eligible for free emergency care regardless of their immigration status. In parallel, refugees often have a poor knowledge of their eligibility to care and report that the services are often difficult to navigate and negotiate. Moreover, the issue of awareness appeared to be compounded by language difficulties, social isolation, and poverty. This vulnerability is enhanced by these enabling characteristics, such as lack of knowledge and preventative care. The last structural barrier to care that we will discuss is lack of health insurance. A study was conducted in a large U.S. Midwestern city in 2013 and sought to find the barriers refugees face when receiving health care. The primary barrier that these researchers found was insurance coverage. According to the Refugee Medical Assistance Program, or RMA, refugees are allowed 8 months of fully federally funded health care for primary and emergency needs, but no specialized or non-emergency care. Those surveyed overwhelmingly agreed that 8 months of RMA was woefully inadequate, especially for those with disabilities or chronic conditions. They also alluded to overall funding shortages that prevent extending RMA eligibility. The two discussion questions for this presentation are, first, what can be done to address the epidemic of mental traumas that refugees have received? Who should pay for the care? And secondly, which barrier to care, cultural or structural, has a greater burden of impact on preventing healthcare access? What can be done to fix it?